My name is Rob Phoenix. My pronouns are he, him, or they, them. I am the Chief Medical Officer owner for the Huntridge Family Clinic in Las Vegas. And what I wanted to have a conversation about today is same-day initiation of care or rapid start for HIV. I would like this to be a very interactive and conversational type of presentation. So as we're going through, if you have questions, Erica is roaming around with a microphone. So if you could please use the microphone so everybody can hear, but also so our people that are joining on Zoom can hear us as well, okay? So I have a tendency to talk very fast, so sorry, you'll have to listen kind of fast too. We are gonna talk about sex, okay? So hopefully that's not offensive for anybody. This is a very open and honest conversation. My style of conversation is very open and honest and very transparent. And this is how I conversate with my patients because I find this to be a very effective way to develop a rapport and develop a sense of trust. So that's how we're going to have this conversation today. Okay. So these are, if I can get it to go. These are my disclaimers. So I am part of the Nevada AIDS Education and Training faculty. I am here today representing only the Huntridge Family Clinic. My views are my views. They do not represent the AETC's views. There are some references in here to AET related resources, but my presentation is not part of the AETC. These are my personal disclosures. So I do speak for a couple pharmaceutical companies. I do have some consulting stuff and I'm part of some planning committees for other organizations here in Nevada. So we want to talk about how do we implement an HIV neutral status when it comes to testing, prevention, and treatment. We want to talk about how do we develop that conversation, how do we implement, how do we identify opportunities to test people? Because the crux of getting people started in care is testing and identifying them. So part of our conversation today is going to be around how do you test and how do you engage people in that conversation? And what does that look like for integration into your practice? We're going to talk about some prevention strategies. We're going to identify some opportunities to start in clinical practice. How do you start same day? And then we'll talk about some of the potential barriers that you may come into and some of the things that we've done at the clinic to work around those barriers. So Huntridge is a LGBTQ focused primary care. I'm a family nurse practitioner. We've been doing rapid start since the end of 2018. My definition of rapid start is same day. Clark County, which is where we live and where I work, their definition is 7 days as rapid start. That's what we've defined as a county. And that's what most places are defining as a rapid start as well, as 7 days. To me, that's faster than what we used to do. Rapid means to me, same day. And I'll talk about some of our data that we've been able to collect over the past from 2021 about our experiences with same day initiation of care. There are some resources from the CDC on how to integrate HIV testing into your practice. Just by show of hands, how many of you are prescribers, whether you're a nurse practitioner, PA, physician, okay? And how many of you are like case managers, peer advocates, social workers? Where are the rest of you? Pharmacists? Okay, great. All right, so when I talk about HIV testing, I'm talking about how do you normalize that conversation because a significant number of people have never had a test for HIV. And if we don't know what your status is, or if you don't know what your status is, then that impacts your ability to stay negative, but it also impacts your ability to help the community stay negative and to help decrease the community viral load. So part of this conversation is how do you have that talk with your patients around testing and getting them engaged in care. Several of these slides are from the CDC on HIV testing and how to integrate into clinical practice. And these are some of the objectives from that. But we want to talk about those opportunities. So as I mentioned earlier, I am a speaker for a couple pharmaceuticals, and I went to some speaker training not too long ago, and I had a very interesting definition of how someone describes themselves with regard to their opportunities to become HIV positive. And it was a woman who is a peer advocate. She's a peer navigator. She is also part of the peer advocacy program for this speaker bureau. And she describes herself as HIV possible. And what does she mean by that? She's like, I have opportunities if I don't implement a strategy of prevention, whether that's condoms or getting tested, knowing my partners, knowing where my partners are coming from, whatever, I'm on a medication for HIV prevention. I have an opportunity to lose my negative status and become HIV positive. And to me, that was a very interesting way to look at how somebody looks at their HIV status and how do they prevent themselves from becoming positive, or how do they keep themselves in that HIV negative status? Is HIV possible? Transmission of HIV in the US still happens very commonly. You can see here, there's a significant amount of people who don't know the last time they had an HIV test. Is there a way to take this out of speaker? Because I can't see and I need to look at a couple of my slides, and I'm old and my glasses don't work. And no, I've been a nurse since the 1900s. So if that gives you any kind of idea, I've been practicing since the 20th century. So really that old. So thank you.
Like that.
Awesome. Okay. So 15% of the people that transmit don't know they're positive. And if you live in Nevada, 1 in 4 people have HIV and are unaware of their HIV status. So that's, pretty concerning in that people have never had a test. 40% of the people that live in Nevada have never, ever had an HIV test. And how do you know what your status is if you don't get a test? And that's kind of the conversation that we want to talk about today. 23% knew they had HIV but weren't in care. And what does that look like? Ryan White defines care as at least 2 visits a year, right? So how many people are getting at least 2 visits a year? How many people need more often visits? And we'll talk a little bit about when you're starting same day start or rapid start for people. What does that look like for follow-up for patients? 11% were in care, but they were not virally suppressed. This is important because this impacts their ability to transmit virus. It impacts our strategies of treatment as prevention. It impacts our strategies of U equals U, which are HIV prevention strategies as well. And 51% of those people were taking their meds and they were virally suppressed. So that's a good number. There are some better numbers within the Ryan White data that says that as much as maybe 90% of our people living with HIV, or another way to define that is people with whom HIV is living, because you were here first, then HIV came, right? So that's a different way to look at this. And that's all about which syllable you kind of put the emphasis on when you're talking with patients. We have lots of opportunities for testing. 7 out of 10 people were at risk or had an opportunity to miss being negative and weren't tested. What does that look like in your practice? How many of you are doing testing in your practice? And what does testing look like in your practice? How many of you are able to do point of care testing in your offices? Only 2 or 3. That's great that the 2 or 3 of you are able to do, but that's really unfortunate that the other 15, 20 of us aren't able to do that. So that is one of the things we'll talk about is what are those opportunities and how can we change that narrative? What are some of the things that are happening in your practice that are enabling you to not be able to offer HIV testing as point of care? It's very easy. There's 2 different point of care tests basically that are bloodborne. There's the INSTI, which is a 1-minute test, which is antibody. There's the ALIR, which is antibody antigen. And those are some things that you can do in your office. They're reimbursable. They're easy for people to learn and you get your instant results. And, you can also use both tests as your proof of diagnosis for your same day start. So it's an opportunity for you to actually get patients tested in the office, be able to know what their status is right then, right now, and be able to offer them same day initiation of care. Obviously knowing that you're going to do some follow-up labs with them as well. So offering this as a routine. So how do you make this part? And we're going to talk in the next session about sexual health history taking and how do you include this conversation around testing? How many people in your practice have been tested? How many have not? What are you doing with the recommendations from the United States Preventive Task Force that recommends that everybody between the ages of 13 and 64 should have at least 1 test in their lifetime for HIV? That is under attack right now with the Becerra v. Braidwood decision, where the state of Texas, the Northern District of Federal Courts, have basically said that prevention strategies like testing are unlawful. And fortunately, the Biden administration has kind of been able to step in and got a hold on this, but we don't know how long that's going to last. And we don't know if that's going to be completely undone. And why is that important? Because it doesn't just necessarily take away HIV testing. It takes away HIV prevention strategies, but it also takes away many, many other potential things. It takes away cervical cancer screening. It takes away vaccinations. It takes away breast cancer screening. It takes away colon cancer screening. It takes away hepatitis C testing. So One of the things that I've been encouraging people to do lately is be health literate and advocate for yourselves, advocate for our profession, and advocate for patients. And these are things that we need to know so we can help patients access care in the best way possible. The HIV neutral, the status neutral of HIV prevention and care continuum is a newer strategy with the CDC, and it is looking at kind of everybody in the center, getting them tested, and then identifying whether they are HIV negative, and could they be somebody who would benefit from HIV prevention strategies, or is this somebody who is living with HIV or with whom HIV is living, and we need to get them engaged in care, get them virally suppressed, treatment as prevention, get them to undetectable equals untransmittable, and then that's a prevention strategy as well, okay? But the most important thing is getting people tested and offering testing for people. So we want to diagnose people, then we want to link them into care. So what does that look like in your clinic? I tell patients, or I tell people all the time, providers all the time, if you can't do this in your clinic, that's okay. But what's your strategy? Where can you refer patients? Who is in your network? Who are your community partners? Where can patients go? So within, how many of you are outside of Salt Lake City? Ooh, most of us. Where are you guys from? Oh, okay, great. That's my last name. Not a fan of the city, but I love my last name. But no, just kidding. Where is anybody else from? Michigan, welcome. Have you been to the Electric Forest Festival? Just curious. No, okay. Just happened to see that on the internet the other day. Anyway, so knowing what your strategy is for linkage of patients in your community. So if you're in Phoenix, you've got some great resources, that you can tie patients into for services, for testing, getting them linked in. If you're in Phoenix, like Nevada, you're in an EHE district. So EHE is ending the HIV epidemic. So there are some additional resources that we have. EHE districts are the 48 counties across the United States and 7 rural states that make up over 50% of all new HIV infections. And we have some special funding from the CDC to accommodate testing to get people into care. And basically with EHE funding, all the patient needs is a diagnosis and they're linked into care. So you can provide their labs, you can provide their provider visits, you can get them their medication, kind of like the old days of that presumptive eligibility with Ryan White. So you're getting patients kind of tied into services right away, trying to take away one of those barriers. Because a lot of people don't have insurance, they don't know how to use their insurance. Many of our patients are health illiterate. They don't know that they have to call the pharmacy to get a refill. They don't know that they're going to have a copay every time they come to the office. When they get their blood done, they don't know they're going to have a copay. So those are barriers that patients are experiencing on a day-to-day basis. So this third step is receive or retention in care. And then the fourth is getting them virally suppressed. And that's where the same day comes in, okay? So early HIV diagnosis allows us to get people on therapy, and it helps to lower the community viral load. It helps to protect against serious complications. The majority of people living with HIV now are not getting to a point where they have a definition or diagnosis of AIDS. We have fewer complications and long-term complications, opportunistic infections than we used to, which is great. We're getting to viral suppression much fast. There's some great agents, some single tablet regimens that are very aggressive in getting people to undetectable in a very quick way. And, increased likelihood of viral suppression 1 year after diagnosis. So if we can get these people linked into care, we can keep them engaged in care, then we lower their viral load and we can improve their life quality, which is what this slide represents. It's a very busy slide, but it shows that when they're virally suppressed more quickly, we maintain their CD4 cells, their T cells, we're actually able to keep them healthier for a longer period of time. And actually our life expectancy for people with whom HIV is living is very similar to those people who are HIV uninfected. So we've done a great job over the past 40 years that we've been dealing with this epidemic of improving our survivability for people living with HIV. We want to remove stigma. This whole conversation, this whole conference is around taking away stigma. This is just another example of how we take stigma away. And there's a ton of stigma still around HIV 40 years into the epidemic. I've been doing this, like I said, I've been a nurse since the 1900s. I graduated in 1990 from nursing school, right? So when I graduated from nursing school in 1990, nobody wanted to get HIV. Nobody wanted to get HIV. And when somebody got a diagnosis of HIV in 1990, that was a very devastating diagnosis. It basically was the end of the life. It was the start of the end of life planning. Now, 40 plus years later, 2023, nobody wants to get HIV. I have never in almost 40 years, I have never encountered somebody that said, yes, I finally got HIV. That's what I've been trying to do my whole life. Never encountered that person. I hope I never find that person either, because we want to end this epidemic, but we have to address the stigma, okay? We need to get earlier diagnosis. We need to reduce transmissions, and it's much more cost effective. So we can save money for people, and all of our insurance plans are focused around money. The PBMs, the pharmaceutical benefits managers, are always trying to squeeze that last little penny out of us, making us do one more prior authorization, one more step edit, trying to get one more medication reduced, or breaking up that single tablet regimen into its 3 or 4 components because we can get the generics for much more cost effective, but not thinking about what the impact on the patient is for those. Okay. There are some benefits. The majority of people that I'm seeing as new diagnoses now are young men of color who have sex with men. And this kind of represents that a lot of our younger people are who we're finding as newly positive. Okay. People that live with, that are at risk, that are heterosexual, or oftentimes don't understand what their opportunity to lose their HIV negative status is. I'm an investigator for a study called Ebony, which is looking at HIV prevention strategies in women of color. It is extremely difficult to enroll patients in that study because women of color don't recognize their opportunities to lose their HIV status as negative. It's really hard. They realize that there's somebody else that could be getting this, but they don't self-recognize, they don't self-identify. So a lot of heterosexual people don't realize this. I hear all the time in clinic that I can't have syphilis, I'm not gay. Well, let me tell you, it's like everything else. Once the gays get it, everybody wants it. It is the reality. I'm very proud of this fact. Nevada is no longer #1 for HIV, for syphilis. Congratulations, we're #5. It's not because we're doing any better, it's because everybody else did worse. But I don't care, because we're normally #1 for all the bad stuff. Like, we've been #1 for syphilis for 4 years, and we're number 48 for healthcare access. So like, we have fewer providers than 48 other states in the country. We have worse education than any other state in the country. So we have a lot of opportunity for improvement, but we did make some improvement in our syphilis numbers this year. Okay. But also, people oftentimes don't talk about sex. So when we talk next session about sexual health history, this is where the conversation of normalizing, taking away the stigma, is so very important for patients. How do you have that conversation? So how many of you have been to a provider and you've actually had an honest to God, true, legitimate conversation about sex? Nobody. Crickets, right? I am 58 years old. I'll be 58 in July. I've never had that conversation with my dad. I don't know how I got here. Just magically showed up. Okay. Everybody in this room, you are the product of barebacking. Okay. Every single one of us. That's how we got here. These are conversations that we need to have with our patients, because this is the reality of what we need to be talking with patients. We need to normalize these conversations. I mean, the first time I heard that, like, I'm the product of barebacking, I'm like, oh, that's kind of offensive. But then I thought about it. It's like, yeah, how else did I get here? Right. So this is going to talk a little bit about, just in the interest of time, I'm going to kind of skip through these. You'll have access to all these slides, but these are talking about some of the different testing that we have available. And like I said, there's 2 real point of care testing that we do in the offices. There is an oral test, has less sensitivity. It's a 3rd generation test, so it's not something that's terribly commonly used. It's great for home testing, but the challenge on home testing is, how do you know that they're testing? How do you know they're doing right? And then what are you doing with those results? How are we getting people into care when they get their positive results? Okay. So you're looking at the antigen antibody test, you're looking at the antibody test, right? This kind of gives you an idea of the window of opportunity for people to have a positive test. So from an exposure to when they could have their first positive test. The most sensitive test is the HIV RNA, and that's a quantitative or qualitative test. So you want to get the one that says, hey, do you have a positive viral load? That's really what you're looking for. So that's kind of your confirmation test. Remember that when you're doing blood draws for patients, there's the HIV antigen antibody test, and there's the HIV differentiation test. So when you're ordering stuff, especially, I'm not picking on LabCorp, I'm just pointing out something that's an opportunity for improvement. But within LabCorp's testing menu, there's a way that you can order the HIV differentiation test only by itself. And oftentimes you'll get that HIV1 or HIV2, and it'll be reactive for HIV1 for some reason, but they'll have a negative antigen antibody test. And I get patients all the time that come in and say, my provider told me I have HIV. Like, well, not technically. This is how this works, and this is what happens. So let's undo that damage. Let's get rid of that PTSD that you've been experiencing for the last 10 days while you've been waiting to get in to see me. So let's figure out how we can do that. So just pay attention when you're ordering testing from your labs. you want to get the antigen antibody testing. And then that should reflect to confirmation of the differentiation between HIV-1, which is the predominant strain of HIV in the world, specifically here in the US, and then HIV-2 is more common in Africa, okay? What are some things that we need to be asking patients? These are symptoms of acute viral infection or seroconversion. I have found that asking patients about symptoms, have you had the flu lately? Have you had COVID? Did you go to the hospital because you thought you had COVID? They did a test and it was negative. Everybody knows the symptoms of COVID. If you ask all of your patients, they can probably just rattle off like 10 or 12 symptoms of COVID. And oh, by the way, if I start sneezing, it's not because I have COVID, it's because they're mowing the grass out here and I'm allergic to grass. So don't be freaking out that I have COVID, okay? Because that could be a symptom of COVID. Anyway, everybody knows the symptoms of COVID. Everybody knows the symptoms of flu. So I found that to be a very helpful tool. And then when I say, have you had a COVID test in the past couple months or couple weeks? They're like, yeah, I did because I felt really bad. How did you feel really bad? I had a fever. My body was hurting. I was night sweats. I had diarrhea. Oh, have you ever had an HIV test? And during the COVID epidemic, we probably had about 8 or 10 people that had gotten a diagnosis of viral syndrome from local emergency rooms and urgent cares. And they did have a virus. They just tested them for the wrong virus. These were folks who came in with symptoms suggestive of HIV. Nobody did the sexual health history with them. Nobody did the conversation around, have you had an HIV test? They tested them all for COVID because why? That's what we were doing for everybody, right? You stub your toe, we need to do a COVID test. Your hair's falling out, we need to do a COVID test, right? So everybody got a COVID test and that's what they were told. You don't have COVID, but we don't know what's wrong, but they didn't test for HIV. So asking those questions, doing that sex positive confirmation, gender affirming health history with patients. Whoops, wrong way, sorry. So I'm gonna basically skip through this. These are people that we should be testing. Okay, we want to be testing at least once in their lifetime, maybe more often, if there's somebody who could benefit from HIV prevention strategies. And remember, HIV prevention is a strategy. It's not just a medication. It's not just a pill. It's not just a shot. It's condoms, it's testing, it's knowing your partners, knowing your partner status, making sure you're getting tested, making sure you're getting treated if you have something, knowing what your opportunities to lose that status of negative are. And then there's medications, there's pills, and now there's injectables, okay? Anybody that has multiple sex partners should be offered testing at least once annually, maybe more often. If you're a man having sex with men, or you're somebody engaging in HIV prevention strategies, you're testing every 2 to 3 months, right? Remember that if you have a bacterial infection like gonorrhea, chlamydia, or syphilis, those people are much more likely to lose their HIV negative status. So maybe they need to be tested more frequently. So making sure you're having those conversations with patients. Remember, if you have a rectal infection with gonorrhea or chlamydia, that significantly changes your risk for acquisition of HIV, because the rectal tissue, regardless of whether you're male or female, whatever your sex assigned at birth was, or whatever your gender identity is, the rectal tissue is the same. Mine's the same as yours and yours and yours and yours. And it's single tissue. It's very fragile. It tears very easily. No matter how much lube or spit you put on there, it still tears. And it's full of white blood cells. White blood cells are what the HIV virus is attracted to. And when you have a bacterial infection, that just brings more white blood cells to there. So it just increases the opportunity to lose that negative status. Okay. So making sure we make this part of our routine. Okay. Talking to people, asking questions that patients understand. Remember, health literacy is a big issue right now. I have patients that call me and say, hey, do I need to go to the same pharmacy to get my pills this month? I'm like, did you change your pharmacy? Then no, you probably need to go to the same place, right? Do you know how to get your refills? Patients don't know how to do that, okay? Making sure that they know how to get tested, okay? Initial testing should involve an antibody test, possibly antigen antibody testing. And then you want to do some follow-up confirmation if they have a positive. And this is kind of the algorithm for testing for people based on the CDC's recommendation. If they have a positive HIV antigen antibody test, then you're going to do a confirmation. And if you're doing this in the office and you're doing the INSTI, which is the 1-minute test, which a lot of us use because it's super quick, it's really fast. It's only a minute. All of us have at least a minute, right? It took me more than a minute to open the package, right? And get everything ready. And then I'm able to test my patients. And you're having that conversation with the patients while you're doing the test. And JP is one of our peer advocates and one of our case managers. And one of the things that he does that I really like when he does testing is just remember that this is a positive test, you have a friend with me, I'm living with HIV, I've been positive for 12 years. I'm undetectable. He's like, I'm living my best life. Yeah, just like that. Okay. But having that support system for somebody when they have a positive test, that's super important because nobody wants to hear this diagnosis, right? No matter how prepared you are for this diagnosis, nobody wants that diagnosis. So making sure you have some strategies in place for when you get those positives, because you will. If you test people enough, you are going to find the positive test. How many of you have ever had to tell somebody that they had an HIV positive test? Was that very easy to do? No, it was not. Okay. I'm a kind of rip the Band-Aid off person and just like, hey, your test is positive. And then I just stop. What can we do for you today? What are your priorities? What are your goals? What do you want to do? I want to get started on meds. And that's what we're going to talk about. So just being able to use silence to your advantage and asking patients, don't ask them how they feel. What can I do for you? Because people are going to be like, well, you can take this away from me. Well, I can't do that, right? I wish I could, but I can't. So that kind of sets you up for negative. How are you feeling? Right now, I feel like somebody kicked me in the stomach. I feel like somebody kicked me in my crotch. I feel horrible. What can we do for you today? How can we help you get through this? What do you need from us? What are your priorities right now? Okay. Questions. If you say, what are your questions? People are going to be, I don't even know what my name is right now. So, just thinking about the words that you're using when you're telling somebody their status and they're changing their life for the rest of their life. Okay. These are recommendations from all the major organizations about why we should be doing this. And they all have guidelines around what we should be doing. Okay. Offering testing, making, I like to tell people now that PrEP is a gateway drug. And people are like, what is he talking about? I know he has lost his mind. It is a gateway drug. It is a gateway for all these other things. It's a gateway to get people into care. It's a gateway to get people to test for diabetes. It's a gateway to get people to talk about smoking cessation. It's a gateway to talk about health promotion strategies. It's a way to get people engaged in care. So yes, PrEP is finally a gateway drug. Thank you. Okay. We want to talk about all those other important things. Among the LGBT community, there are so many people who have social stigma around getting cervical cancer testing. A lot of people born with vaginas don't want to have that. Any of you signed up for a monthly pap smear lately? Anybody with a vagina? No. So think about if you're a trans person and you have that part that you really don't want, you're born with the wrong pieces in your body, how much harder is it to get that cervical cancer screening? So what are the things that we're doing in practice? PrEP could be that gateway to get people into care. Okay. This is from the AETC website. This is about rapid initiation. So who is rapid initiation? So we've talked about testing people. We've talked about like, what are you doing? How are you doing that? How are you having your conversation? And now let's talk about, you got that positive test. You got the patient sitting in front of you. What are you going to do? Okay. How many of you have prescribed HIV medications or treatment medications in the past? Okay, good. How many of you see HIV patients on a regular basis? Okay, the rest of you primary care? Good. Okay, so in your primary care, if you have somebody that comes in and you do a test, what's your goal? What's your strategies? What's your opportunities to engage them in opportunities for same day start? And that's what we want to talk about now. So individuals who should be offered same day or rapid initiation, remember your jurisdiction is going to help you define what rapid is. And like I shared about Clark County, which is the TGA for Las Vegas. So if you know anything about Nevada, we're largely two cities. We're Carson City and Reno, and then Nevada or Las Vegas. The majority of people live in Las Vegas. So the TGA consists of Clark County, which basically goes from the Arizona, what's the state? Utah border to the California border to the Arizona border. Wow, I'm having geography was not my strong point in school. So we have a very big area, but we also include Nye County, which literally Nye County runs across the entire state just above. It's one of the 14 states that has legalized prostitution, 14 counties. And then we also have Northern Arizona, Mojave County as part of our TGA. So we have a very large geographic area that we cover. So in our jurisdiction, we defined rapid start as 7 days. The majority of the clinics are doing same day start when possible with patients. And we're doing everything we can to get patients engaged in care the same day that they get their diagnosis. Okay. So looking at people who have that confirmation test, and for my practice, we do 2 point of care tests. And if they're both positive, then we consider that to be an HIV confirmation diagnosis. Then we're doing confirmation labs. We're drawing for the HIV RNA. We're doing a confirmation for the antigen antibody. We're doing the resistance testing. We're getting all the other labs as well. Okay. And then we're starting the patients on medications. And we're talking about what are those medication options. And we basically have 3 same-day start or rapid start medications. We'll talk a little bit about those in a second. This is also applicable for those people who've been out of care. So bringing somebody back into care, this can be a very valuable strategy for getting them back into care if they've been out for a while, and being able to reinstitute same-day or rapid start for them as well. People that should not be same-day start are those people who have some kind of opportunistic infection. You think there might be something else going on. You think they, maybe even neurosyphilis. We're seeing a ton of neurosyphilis across the US. So people are coming in with, I saw the highest syphilis titer I've ever seen in my entire almost 40-year career recently. So I do work at the prison system for the state of Nevada. And we had a gentleman that had an RPR titer of 1 to 4,000. I know, right? That's exactly what I did. It's like, and then the staff were like, he can't walk. I'm like, really? They're like, I think he's dehydrated. I'm like, yeah, I think he's got bigger problems than that. So it happens. He was 70, never tested before in his entire life. Yeah, right? How did he get it? Who knows who she was, right? Or he. No, it was she. He was all she's. It was all about she's. That's what he said. Anyways, some of them just happen to have penises, but whatever. Okay. So individuals who have some kind of an opportunistic infection, they're sick, they look like they might have something going on, might not be candidates for same-day starts. Okay. So on your intake, you're going to do some compressed labs. You're looking at the HIV RNA, you're looking at the viral load, which is the RNA, you're looking at the CD4 count, you're looking at a basic chemistry assessment. You should be probably looking at your hepatitis A, B, and C. We have a ton of hep C in the community. We have a ton of people who are co-infected with hepatitis C and B and HIV. So we want to make sure we're getting those people treated as well. You can treat hep C and HIV at the same time. Okay, you just have to be careful with some of the selections of your medications if you decide to do that. Looking at their TB risk, looking at, a quantiferin gold or some way of testing them for TB as well. And then if the patient's agreeable, getting them started on medication. How many of you have the opportunity, have an ability to give samples out in your practices? Oh, 2 of us. Great. So what is your strategy for same-day meds, right? So if you're going to start somebody if you're going to rapidly start somebody and you have to wait 30 days for medications, that just defeated your rapid, right? So what are the strategies that you have to get patients medications quickly? Because why? Insurance is going to pay for them after you do like 5 PAs and get 3 denials and go to the advancing access programs or the patient assistance programs, right? So what does that do for your patients in the 30 days that's taking? That's allowing their virus to remain uncontrolled. That's allowing them to potentially share this with other people. That's allowing their CD4 count to be negatively impacted. So working with community partners. So this is where your pharmacies can be very helpful. So finding a community partner that's a specialty pharmacy that can get your patients quickly enrolled in medication therapy. So maybe they can have the samples for you if there's a way that they can get you started on the medications. All the 3 companies that make our HIV meds that we use for rapid initiation have a sampling program. So Gilead has a sampling program, Janssen has a sampling program, and so does ViiV. They all have sampling programs for their HIV treatment medications, okay? So figuring out in your community what those resources look like, because if you can't get medicines to patients, it's less helpful than on the rapid starts, okay? In that recommended regimens, there's the dolutegravir, Tivicay, which is the brand name, and this recommends with a TAF-based regimen, but there's also dolutegravir with rilpivirine, which is brand as Dovato. You also have bictegravir TAF, which is brand as Biktarvy, and then you have darunavir, cobicistat, and TAF, which is brand as Simtuza. Those are your options for same-day start medication. And there are going to be times when you choose one versus another. Sometimes it's access. Sometimes it's ease of ability for patients to take a pill. Sometimes it boils down to the size of the pill, okay? Size matters. Ask any gay guy, size matters, okay? Small pills sometimes are better than big pills, okay? This is the only time that small is better sometimes, okay? So you want to talk to patients. Color is good as well. Sometimes they, that red pill is going to match really well with my nails. Okay, great. I don't care. Let's just take the red pill, right? So talking about patients, what it is that's going to help them be successful in getting their medications. Okay. Follow-up. I typically see my patients within a week. Why? Because I want to make sure they're okay. They've had a really bad day today. I thought my day was bad because my e-bike got stolen. That's not anything close to getting a diagnosis like this. Okay. So making sure patients are coming back in a relatively quick matter of time, linking them with a peer advocate, with a case manager, somebody to help support them, because most of these folks don't have a family member that they can go home and say, you know what just happened to me today? I got a diagnosis of HIV. Very few people have that support system at home. And it oftentimes changes the dynamics of their relationship. So that is something else that you need to help patients prepare for, is what's going to happen when you share this with your partner, with your wife. We recently had somebody that was on injectable HIV prevention medication who lost his HIV status. He is from a community that does not endorse same-sex intercourse. Comes from a Middle Eastern country, so it's very taboo in his country, and he has a wife who doesn't know his status. So how do we share that conversation? How do we have that conversation around what are you doing to protect your wife because you're still sexually active with her? What are you doing about your partner? How are we getting him tested? Having those conversations. So these are the kinds of challenges that you run into when you do same-day initiation. So get that confirmation, getting them treated for opportunistic infection. The recommendations now are, for a long time, if their T cells were under 200, we would start them on Bactrim and or azithromycin. If you're doing same-day initiation or rapid start, recommendations don't necessarily support that anymore. So looking at what your patients are bringing to the table and deciding if you need to add in the opportunistic infections for them as well. The recommendations are on the right-hand side of the screen. Doesn't matter, get them on something. If you do have somebody who has become positive that was on injectable HIV prevention, cabotegravir, you need to be thinking strongly about a protease-based regimen. So darunavir, boosted darunavir would be an option for them because they may have some low-level resistance to integrase inhibitors. So they may not be a candidate for dolutegravir-based regimens, and they may not be a candidate for bictegravir based regimens because those are integrase as well. And cabotegravir is our newest integrase inhibitor. So in our patient, we started him on a darunavir-based regimen while we were waiting for his integrase resistance and stuff like that. His viral load came back at 154,000. Yeah, so he was obviously positive. There is a condition called Levi or Levi, depending on which part of the country you're from, whether we're Levi's or, 501s, whatever. So low, what does it stand for? Something viral infection. So Levi is where, I'm totally blanking on what it stands for, but anyway, it's where people who are on injectable HIV prevention medication become positive and they don't get a HIV positive test right away. Their antibody test doesn't turn positive for several months, but they're still having this low level of viremia. So they're technically still positive, but the cabotegravir is keeping them virally suppressed. So it's not able to pick up their HIV positive status right away. So those patients are potentially transmitting. So that's why the FDA labeling for cabotegravir injections is every 2-month testing to try and help catch those things a little bit sooner. Day of visit, we talked about what should be happening. Probably the most important thing is making sure they have resources. Poverty level has changed dramatically across the US. Think about in the community where you live, what's your rent now? Okay. We rent a house. Our rent used to be $1,700. We decided to give up the lease and they are now renting that same space, no improvements, still has the big roof running through the living room, $2,600. Okay. How many have had $1,000 a month increase in your salaries? Right. So those are real challenges that patients have. Food insecurity. If you have a patient who needs to take a medicine with food and they have no food, how many people get food stamps? The average food stamps around $200. Everybody gets around $200 a month, but I have patients who get $11 a month. How do you live on $11? How do you eat? That's one pizza at 7-Eleven and a soda. Okay. What do you do for the other 29 days of the month? So simple question, in the past 30 days, have you had any days without food? You will be surprised how many patients say yes. and then knowing what your resources are. Again, we don't all have food banks in our offices. So how can we link patients into services for food? Housing, if you have patients who are housing insecure, what are the housing sources that we do? Okay. So these are a little bit about us. This is who we are. We started in 2013 when Nevada got full practice autonomy for nurse practitioners. We modeled our program after the Max Clinic in King County, Seattle, Washington. So we're largely same day walk-ins for as much services as possible when it comes to HIV services. Okay. That's very chaotic someday in my office. Okay. But it works. Why? Because people don't plan to miss their visits. People don't plan to be homeless. They oftentimes like, oh crap, last pill, just took it. Really? You didn't know 30 days ago that you're going to be running out of pills? Come in today, we'll get you filled, right? Okay. It's our mission statement. We are all nurse practitioners. Okay. This is the staff. This is a little outdated. These are our emotional support animals. Okay. So on the left-hand side, you see Jack and Nala and Cookie. Jack and Nala are no longer with us. We had a tragic accident last year that we lost them. And now on the right-hand side, we have Bruno and we have Cookie. And they're in the office with us every day. And it's amazing how important they are to our patients and how important they are more to the staff, especially me and JP. Okay. They go home with us every day. Huh? Oh yeah, we can meet them all tomorrow. Maintaining a social media presence. This is some data from us. This looks at our data for our race. You know, we're a majority state. And a lot of our population is Latino or Hispanic. So about 33+% of our patients were Latino in 2021. Largely men who have sex with men or male was our demographics for HIV transmission. This is where our referrals came from. We had a collaborative agreement with the Gay and Lesbian Center in Las Vegas, and we were getting all their same day starts or their new positives. We tested about 5,000 patients a month during 2021. Okay. We had a big spike in April. I think this was, I'm not sure exactly what happened, but it was also EDC and Coachella and a lot of other things. So who knows what it could have been. This is our gender. Oh, and this is our same day start. So we've been doing same day start since 2018. And I first started doing same day start when I went to a conference and I came home after hearing about same day start in other jurisdictions. And I said to my TJ grant administrator, I'm like, why are we not doing this here? And I still have that email. And that's why we do same day start, is because I think HIV is important. I think everybody deserves access to same day care. I think everybody deserves access to medical care, regardless of your gender, your orientation, your cultural backgrounds, whatever baggage you bring to the system. I think you deserve care. And that's how we do it. And this is a publication that we did on some of our results. We were testing at a behavioral health group that did a lot of substance use treatment. And this was just a poster that we did at a substance use conference on linkage to care using a peer advocate. So that's my story. I'm sticking to it. So I'm happy to answer any questions that you guys may have. Thank you. And this is our mobile unit. We did not brand it with HIV at all. We wanted to be able to pull into any community and be welcome. So we didn't want anything like, you know, there's a group in town that says, hook up with us. You know, we didn't want to be that group. We wanted to be somebody that could pull into the Asian Pacific Islander community or Taco Festival or the Gay and Lesbian Pride Festival and be able to feel welcome and be able to engage patients in testing. So just some of the community engagement that we do. On the left is our condom couture. So Jesse, one of our staff, that's not Jesse, that's his dress. He wore that dress, and I'm just kidding. But it's all made out of condoms, and Jesse won first place with that. And then we've been really advocating for decriminalization. We've been doing a lot of advocacy work. So this is JP at the International AIDS Conference in 2022 in Montreal. And we've been working really hard in the state of Nevada to try and decriminalize HIV. And this is some of the work that we've been doing this year with our legislative session. So thank you very much.